Good evening, everyone. We're so excited that you have joined us for another one of our webinar series. I'm Dr. Edith Bracho Sanchez. Tonight we're doing things a little bit differently. We are pausing from the regular types of health topics that you have seen and hosting our first community series. We're going to be talking all about caring for children through potential changes in the health insurance landscape. And while we give people a moment to join, I just want to remind you that we are on social media at Kids at Columbia. We are posting not just advice and tips, but we also post regularly about our events, such as this webinar this evening. We also have a newsletter that has all kinds of things happening at Columbia Children's Health, amazing things that our faculty are doing. So we also invite you to sign up for that. We will be sending you a link after this webinar, so don't feel that you have to scan the QR code right now. We also have an exciting webinar happening next month. It is going to be on February 27th at 6 p.m. We have the director of the AAP Center of Excellence in Social Media and Youth Mental Health, as well as one of our own faculty members and someone from the Department of Psychiatry who's going to be talking to us about early childhood and media. And there's so much to talk about on that topic, just like on tonight's topic. So let me go ahead and introduce the amazing people that we have with us tonight. I'm so excited to learn from all three of them. So first, we have Dr. Adriana Matiz. She is a professor of pediatrics here at Columbia. She's also the medical director for NewYork-Presbyterian Center for Community Health Navigation. We have with us Dan Walter as well, who is a senior policy and government affairs analyst at the American Academy of Pediatrics. And last but definitely not least, we have Stephanie Glier, who is a senior director for federal advocacy at the American Academy of Pediatrics. Welcome to all of you. I'm going to stop sharing my screen and we're going to get right into it. As a quick reminder for everyone who's tuning in this evening, you can send us questions through the Q&A. You can also, we will incorporate them as we're speaking, but we're also going to be saving time for questions at the end. We know that there's a lot of questions around this topic. So I introduced all of you, our wonderful panelists this evening, with your professional titles, but having met you and worked with you all, there's so much that you do that isn't really captured in a title. So I wanted to start by briefly asking you to describe what you do and how it relates to or overlaps with children's health insurance coverage. So let's maybe go to you, Adriana, first.
Sure, great. Thank you, Edith, and thank you for inviting me. So as you mentioned, I'm a general pediatrician here at Columbia. So I practice pediatrics in Washington Heights, where I work with our residents and our medical students in terms of our educational programming. I'm also the medical director of a center which oversees all of our community health worker initiatives. And that's largely for our patients who are insured on Medicaid. So high-risk patients who are at risk for preventable utilization. And so I've developed a program that's now in its 20th year supporting families who are largely insured with Medicaid. And that includes now pediatric families, adult patients, and obstetric patients. And then the third hat that I wear that I think is relevant for tonight's conversation is that I was the physician lead for a large Medicaid waiver grant opportunity, probably now going back about 8 years, in partnership with the hospital. That goal was to develop new efforts and approaches to caring for complex children, medically complex children in our institution. So that involves care coordination models, both outpatient and inpatient initiatives.
And we have all benefited so much from you leading that program. I mean, us as providers and also our patients, truly. Stephanie, let's go to you.
Thanks, and thanks for having us here tonight as well. Dan and I are both staff at the American Academy of Pediatrics. And for those of you who don't know, the American Academy of Pediatrics is a large membership organization. We represent about 67,000 pediatricians and pediatric subspecialists across the country. And we love our pediatricians, but we also keep kids as our North Star. So the goal, the mission of the AAP is to promote the health and well-being of all children. And that means that we work on a huge array of issues. Dan and I are both part of a team that works specifically on children's access to care, any care that they need, and that includes their health insurance coverage. So we work on policy issues at the federal and state levels that are related to how kids get their health insurance coverage, what is covered, and whether that's actually affordable for families and whether it works to make sure that pediatricians are able to keep caring for those kids as well.
Yeah. Amazing. Dan, we'll go to you next.
Thanks. Yeah, as Stephanie said, I'm Dan Walter in AAP State Advocacy. So we're in the AAP headquarters just outside of Chicago, and we work with our state chapters on all different issues that chapters are working on at the state level. Unlike our federal affairs colleagues, we don't do direct lobbying. We work with our chapters who are really doing tremendous work on the ground in their state capitals, with their lawmakers, with their state agencies, to improve care for kids. As Stephanie mentioned, we work on all things access to care, so that includes Medicaid, CHIP, the regulation of private insurance, and many other issues. But we've really seen a lot of, in my time at the Academy, we've seen states make tremendous effort to expand and improve care for kids at the state level, largely thanks to a lot of advocacy work done by our chapters and other advocates. And so I think this is a really important discussion tonight, as we kind of in a crossroads in a number of different ways.
Yeah. And I will just say that I jumped at the opportunity of having you both. I think when I reached out, it was sort of like, oh, well, do you want Stephanie, who sits at the federal level, or Dan, who's at the state level? And I really just jumped at the opportunity to have you both with us tonight, because these programs truly are federal and state partnership programs. So we're grateful to have you both join us and give us your insights. So tonight, we're talking about health coverage, of course, and specifically the way that children are insured through the Medicaid and CHIP programs. And I thought before we start diving into what may be coming, Stephanie and Dan, I wonder if you can walk us through where things stand today, to really just give us the big picture lay of the land of where things are.
Yeah, it's always helpful to know where you're starting before you think about where you might be going next. Medicaid and CHIP are these foundational programs for children to cover children, to make sure that they can get the care that they need. Today, more than 36 million kids in the country are covered by Medicaid or CHIP, and that's almost half of all kids. So almost 1 in 2 children across the country is covered by these programs. That means that as Dan and I are working on kids coverage, kids access to care, these are the primary programs that we are thinking about, making sure that they are robust, making sure that they're working well, that families can access them. And not only are they there to cover almost half of all kids, but they also are designed specifically to meet kids' unique needs. So Medicaid has this really important benefit built into it. It's Medicaid's best and worst acronym. It's the Early and Periodic Screening, Diagnostic, and Treatment Benefit, EPSDT. It just rolls right off your tongue. It makes absolutely no sense. I don't know why there's not another vowel in there to make it into a word, but EPSDT. Once you become a Medicaid fangirl, you also might get to know EPSDT yourself. EPSDT is designed to ensure that any kid who's enrolled in Medicaid can get access to any medically necessary care. So any care that a kid needs is supposed to be covered by Medicaid, even if the program doesn't typically cover it, to help make sure that those kids can learn, play, thrive as they go. And that makes it really the gold standard for the type of coverage that we want kids to have, to ensure that they can get access to the care that they need when they need it, provided by someone who is trained specifically to care for kids. We know that not only is useful for them to get the care that they need in the short term, but also that Medicaid works to support kids in the long term, that the kids who are covered by Medicaid as kids, not only do they get that care right away, but they also have better health status as adults. They have higher educational attainment, lower rates of justice system involvement, a higher earnings over the course of their life. Like, it is a really, really successful program to support kids' health and well-being over the course of their life. It is a state-federal partnership, which makes it complicated to understand, but also means that there are policy levers happening across the whole space. So there are federal policies that we can talk about that are happening with Congress. There are regulatory policies happening by any presidential administration, and then every state gets to operate their program a little bit differently. And maybe I can turn it over to Dan to share a little bit more about what that looks like today.
Sure, thanks, Stephanie. Yeah, I would say that every state getting to operate the program its own way has been both good and bad historically for the program, in terms of improvements and expansions, because there are these federal parameters under which state Medicaid and CHIP programs must act, but that flexibility also has historically offered them opportunities to offer either less coverage or to make coverage more difficult to get. We've seen a lot of push-pull, though, over the years between the state and federal governments in terms of improving that care for kids. And I think in the last several years, we've seen Medicaid and CHIP do exactly what they were designed to do, which is step in when there's an emergency, which happened with COVID. And we saw the federal government make everyone stay on the program for several years. And the federal government fund the Medicaid program at a higher rate, increasing the federal match to help states do that. So it really responds to emergencies. Both programs respond to emergencies. Medicaid has more flexibility to do that. But then, of course, now we just went through the unwinding where we had to redetermine eligibility for everyone in the program, and 5.5 million children have lost their coverage. So starting from whatever we're talking about happens federally, we need to get those kids back into coverage. And it's been sort of this tale of two cities with what's happening, because while that's been taking place, we've also seen all this incredible innovation. New York, we were just talking before we started, now has 0 to 6 continuous coverage. That's one of 9 states now that have expanded eligibility from 0 to 6, or one state has 0 to 3. Tremendous. We've really learned from the experience of the unwinding that we need to do better with keeping kids enrolled. And so there are steps being taken to do so. All states have to have 12 months continuous coverage now, thanks to Congress too. We've seen considerable efforts related to health-related social needs or social determinants of health, related to housing and nutrition, all kinds of things being covered now through the Medicaid program in that regard. And so we have this we're in this delicate place where we have a lot of kids we need to get back into coverage. At the same time, we've seen all these improvements because of some of what we learned going through the unwinding and just historically with the program that have improved. And then we're going to respond to whatever happens federally in the next few months.
Which is a perfect segue to the question I wanted to ask you next, right? I think we're all hearing rumblings out there about potential changes to Medicaid coverage. Stephanie, can you tell us what is really the concrete concern at this time?
Well, I will admit that my crystal ball is a little bit foggy, so I will give you my best guess about what we are looking at here in Washington, D.C., but there are still a lot of unknowns. So, of course, the political landscape that we are entering into right now, we have a new Congress and we have a new incoming presidential administration, and we will have both chambers of Congress and the White House controlled by the Republican Party. So we call it a trifecta, and that changes a lot of the ways that a new president will approach their political agenda, especially in the first 100 days, the first year of their term, because they have a lot more ability to move some of the major pieces of their agenda. Medicaid, interestingly, has not actually been a primary part of anybody's political agenda. There are not a lot of folks in Congress or in the incoming administration who have big ideas for how Medicaid needs to change. However, there is a lot of effort to think about doing things like renewing the existing tax cuts that the President Trump was able to put through during his last presidential administration, and that is a really expensive policy. So the Congress, the new Congress and the incoming administration are all thinking about how they will pay for that, what kind of offsets they will use to cover the cost of renewing those tax cuts. And unfortunately, Medicaid has become the primary target for trying to find ways to save federal spending in order to offset the cost of that policy. What we are looking at right now is a big suite of options that Congress will be discussing over the next couple of weeks, in particular, possibly over the next few months, to find ways to cut down on the total amount of federal spending that goes into the Medicaid program.
Tell us, Stephanie, and it's totally okay if we're getting into, and you tell me, speculation and something that we don't really know much about yet, but is there a sense of a range, right? Like, we're talking about potential cuts. Like, are we talking drastic cuts? Are we talking targeted cuts? Do we have any sense of what exactly we're talking about?
Yeah, it's a great question. Just earlier this week, a number started circulating around the political spaces, and it looks like the House Republicans are hoping to save about $2.3 trillion by cutting the Medicaid program. That is a massive amount of cuts to federal spending in the Medicaid program. There are a bunch of different policy options that are being discussed, that each of them comes with their own set of challenges. Each of them comes with their own estimated savings. I'm happy to share a little bit more about some of those, and we can talk about what that would actually look like for enrollees. And again, to your point, some of those can be a little bit targeted, and some of them are really not. Some of them are really blunt. So right now, the way that Medicaid works is that it is a defined benefit program. So if you are a Medicaid enrollee, you are guaranteed a set of benefits. If you get into the program, you're guaranteed that set of benefits regardless of what else happens. There's a big conversation about changing it from a defined benefit program to a defined contribution program, which would mean when we talk about that, that would be a fixed amount of money that every state could draw down from the federal government. So rather than saying, if you need care, you can get the care regardless. So if you have a sicker population, then you spend more money and you also draw down more federal funds. If we shift instead to a defined contribution program, that's things like a block grant or a per capita cap model. That limits the total amount of money that the federal government would be willing to give to any given state. So a block grant would be a fixed amount per state, a per capita cap would be a fixed amount per enrollee. And those are ways to ensure that the federal government knows how much they're spending on Medicaid, but also can reduce the amount of money that they're spending on Medicaid pretty drastically. The downside for enrollees, of course, there is that if there are more needs than whatever assumptions were built in when you sort of bake this policy in the first place. If an enrollee is sicker, if a person enrolled in Medicaid has more needs, they might not be able to get the care that they need through the program. So it would stop being a guarantee that they would be able to get whatever the care is that they need. If somebody is sick, if somebody has a catastrophe or an emergency, if they need a really expensive drug, if there's a new technology available, all of those things are big unknowns and make it really, really difficult to rely on Medicaid being the robust health insurance program that we know that it has been for almost half of the nation's kids and millions of other folks as well. The more targeted policies that are being discussed right now, one of the more targeted policies anyway, where people are trying to avoid as much impact on kids and on older adults, who are two major populations that rely on the Medicaid program, is to implement work requirements. So right now, Medicaid does not include any work requirements. You do not have to prove that you are working in order to be eligible for Medicaid, to be able to get Medicaid coverage. And there is quite a lot of interest among Congress in implementing Medicaid work requirements, either as a requirement for all working age adults in the program, or as an option for states to be able to pick up if they decide that that's a policy that they want to pursue. We have seen several states try to do work requirements for Medicaid in the past, and the results of those are not very inspiring. In general, we have found that for Medicaid enrollees who are able to work are usually already working. And so adding in a work requirement policy adds in a bunch of red tape, but it doesn't actually do a lot to help people decide to get a job if they weren't already trying to get a job. When we think about what the impact is on kids, that also really does impact families. So the parents who are part of the population that is typically targeted by a work requirement policy often do lose coverage, and that has a big impact on the family as a whole. If that parent is not able to get their own health needs met, that certainly impacts the way that the family dynamic is happening, the financial stability of the family, the health and well-being in general of the kids as well. There are a couple of other bigger, broad policies under consideration for Medicaid. As Dan mentioned, during the COVID pandemic, Congress decided that Medicaid was really important, and so they raised the federal funding rate. What's called the FMAP, the Federal Medical Assistance Percentage, which is, so for every dollar that is spent on Medicaid, some portion of it is federal and the rest of it is state. Right now, there is a guarantee that the federal government will contribute at least 50% of every dollar. So 50 cents of every dollar are federal. In some states, that goes up to, I think it's 76 Is that right, Dan? Okay. So depending on the state's per capita income, the baseline matching rate that the federal government kicks in varies. So if the state has a lower per capita income, they get more federal share for every dollar. There are also a few specific areas where Congress has decided that something is really important, and so they've offered a higher matching rate for something specific. So for example, there's a higher matching rate for some home and community-based services to make sure that states are able to prioritize offering care to folks outside of institutions. There's a higher matching rate for the Medicaid expansion population. So the states that have adopted Medicaid expansion for working age adults, those get a higher matching rate than the baseline Medicaid population. So there's a conversation in Congress right now about messing around with the federal matching rate. So reducing the total share of every Medicaid dollar that the federal government would contribute. That's it sounds like it's just sort of moving a dial around, but in practice, we know that that's actually a major cost shift to states, and states do not have the opportunity to go into debt the way that the federal government does. States have to operate with balanced budgets, and so it's not easy for a state to just sort of decide to pick up millions of dollars that they were previously getting from the federal government. I'll stop there.
Stephanie, someone just asked in the chat if this recording will be available later, and it absolutely will be available later. We're going to put it on our YouTube channel. We're also going to send it out to everyone who registered. We'll send a link. And I have to tell you, I may rewatch myself because you just gave us so much information in a short period of time. And also, and we'll get into some of this in a little bit, but for those of us who are hoping to be advocates for continued coverage for children, I think you also touched on some of the consequences, right? Like you do this, but then this may happen, and we have some experience, right? So I will be rewatching myself because I do hope to be advocating for children in the coming months and years, right? Dan, I wonder if we can go to you to weigh in a little bit about what some of the changes that Stephanie's mentioning are on the table may mean for the dynamic with state governments. And, you know, Stephanie mentioned some of it. I wonder if you could tell us a little bit more and also what it may look like in New York.
Yeah, great question. And I think going back to Stephanie's point about this being whichever of these proposals they're all a cost shift to states. And I think that's got to be a significant part of our messaging when these do crystallize, because states are going to be left holding or liable for paying for costs above whatever the federal government decides it won't pay for anymore. So that's a significant part of any of these proposals. I think we do have some experience with some of them, and I can talk a little bit about that. Stephanie mentioned work requirements. So last time the Trump administration was in office, they did invite states to apply for waivers to Medicaid to institute work requirements. And we had 11 states approved, many more under development. About half of states had a waiver under development, but only one state implemented, which was Arkansas, and 18,000 people quickly lost coverage because of this work requirement. The process of that happening, the state had to apply for had to propose an 1115 waiver, and there's a comment period at the state level. So then the state agency takes in all these comments and finalizes the proposal that it sends to the federal government. And then there's a federal comment period, and AAP chapters and other advocates were really instrumental in filing comments, even though those comments didn't stop the Trump administration the first time from approving those waivers, and in the case of Arkansas, it being implemented. What they did do is build an administrative record documenting the harm, which then was instrumental in several court cases which overturned those work requirements. And we even had an appellate court ruling. It just to give a little history, it ended up going to the Supreme Court, but the Supreme Court basically sent the cases back because the Biden administration was in office at that point and was in the process of building the case to undo the work requirements. All of which is to say that a lot of what happens at the state level will depend on whether or not Congress makes these options for states, or whether or not Congress just makes wholesale changes to the Medicaid program and then states have to implement these changes. If it's the form, if they make these wholesale changes, whether it's work requirements, per capita caps, block grants, et cetera, states are going to have to do it. And there will be litigation and all of those things, but there's a lot less decision making that will happen at the state level in terms of meeting the federal law. If it's an option for states, like was the case with work requirements the first time around, then we're going to see states kind of moving in two different directions, and states that will take up those options and look to, if it's a per capita cap or a work requirement or a block grant, to try and implement that, and other states simply won't do that for different reasons. So we will, a lot of kind of the strategy at the state level will depend on what happens and the decisions that are made in Congress. But I think irrespective of whether or not it's an option or whether or not it's mandatory, we really do have to demonstrate, speaking of advocacy, just how this, the numbers that Stephanie just mentioned are truly enormous, and the health system can't absorb, a cut of that size and not feel consequences up and down the line. So we need to let lawmakers know, particularly at the state level, and particularly governors, that cuts to Medicaid are going to have profound impacts on the healthcare system and families and the kids that you all care about. To make that case, it's what worked last time, and I think we can do it again. But we're going to have to do that once we know exactly what we're looking at from Congress.
Dan, as you're speaking, I'm reflecting on how complex this may be from state to state, right? And how confusing it may be for a family who just wants to see their doctor, right? Like, it's just, you have a need, I just want to see my doctor. We as physicians are trying to wrap our minds around this, right? And it's hard for us and challenging for us. Imagine a family who is just wanting to see their doctor, right? For whatever need they may have. So I want to go to you, Adriana, next. And, I wonder if you can tell us a little bit about how this plays out on the ground, right? Like CHIP versus Medicaid. We're talking about different levels of coverage. And I wonder if you can tell us how that usually plays out, and also how it may vary and how coverage may vary depending on what's targeted, right?
Sure. So I think it took me a while to figure this out. So it's one of those things that, we practice medicine, right? Where we'll see the child, it doesn't matter. And some of us in our settings, it doesn't matter. And in other settings, it matters quite a bit. And physicians really know this. But I think one of the things that really is important to understand is that children in New York State who are on Medicaid have a different benefit package than the children who are on CHIP. Even though in many ways the programs, philosophically are aligned, the nuances are quite different. So in New York State, generally, like in my population, in my practice, the children who are born in the United States qualify for Medicaid in New York State. It is those children who are undocumented, not asylum seekers, but undocumented, who will be on the CHIP program in our population, in our practices here at Columbia, in general, or families who do not meet the income level for Medicaid and so want to buy into the CHIP program and pay, a small fee, sort of like the exchange model in adults, right? So when we think about those two populations, we may have a very medically complex child in either of those two insurance models. But at the end of the day, the benefit package for Medicaid, which I like to refer as sort of like the golden card, right? Because it really gives you, it's like a golden ticket. It gives you access to so much more than the CHIP model. And what can that look like on the ground? So if I have a child who's medically complicated, who has autism, who needs home-based services, who needs to be enrolled in the OPWDD program, which is a program that supports persons with disabilities, with home-based therapies, et cetera, that can only be acquired by a Medicaid recipient. So somebody who is on CHIP will not qualify for that, okay? We would have to go through a Medicaid waiver situation, which is quite complicated for many of our families, to potentially access Medicaid funds for that. So that would be one example. Another one might be a child who needs home nursing services because they have a tracheostomy and they're home vented. Well, the limits on the funding for that in a CHIP model are going to be much greater, so greater limits. in what's feasible and funded compared to a child who's on Medicaid. So again, two very different streams of funding, leading to very different resources that we can put into the home or for care coordination services, et cetera. So really quite complicated. And to families, like you said, they may have been on Medicaid 1 year, and then the next year, maybe mom got a job, so now she can't get Medicaid. So now she's going into CHIP because her employer insurance is too expensive, right? So to them, it's like, well, I just want to see my doctor. She takes Medicaid or CHIP. It's the same managed care organizations often, right? So it might be a Health First or Affinity, which are local organizations that might do Medicaid or CHIP, both, right? So to them, they think it's the same, but actually at the end of the day, the package is very different. So quite complicated, right? So a lot of what I just described is the opposite of universal healthcare, right? Which would be just the same for everybody. And everybody has sort of a golden ticket version, right? So two very different things and very complicated for families, and really leaves a lot of children in a gap of coverage from my perspective and what I've learned through the years.
Yeah, and Adriana, that's so helpful, and something that I'm learning myself again, because we treat the child, right? They come to us at an appointment with us. We just treat them. We do what's medically necessary and indicated. So lots to learn.
Actually, one more thing, Edith, that I just reminded that I think it's important for our audience to understand the concept of copays. So in Medicaid, in New York State, and in our institution, copays are like negligible, right? So Medicaid recipients in our practices generally don't have large copays of any sort. But if you're on CHIP, your copay for your inhaler to prevent your asthma attacks, right, might actually be $100, right? Which for a family who is, maybe just below the poverty line to make Medicaid, so made it into CHIP, $100 for an inhaler a month can be an exorbitant amount of money. So we have a lot of kids on that CHIP program. Their medications become a real barrier. That's another one, real tangible one I wanted to mention.
Yeah, and I so appreciate that, Adriana. And we had a question in the chat that came in that I think speaks to exactly what you're talking about. And you lead our program for children with complex medical needs, but when we're talking about all of these potential changes that are on the table, the question that came in is, do you think that the outlook for kids with chronic conditions is different from quote unquote healthy kids?
Yeah, and to me, the answer is absolutely yes. I feel, what Stephanie and Dan have shared today makes me it's unsettling. The thought that our pediatric high-risk populations, which are growing, right? These are children who 30 years ago would not have survived a NICU stay, right? An X26 week or X25 weeker. These children, luckily, with advancement of science in our institutions, are surviving. They are thriving, right? But they need services. And so having cuts, I think of them. The other population, which just to mention to this audience that is growing, and I know you can relate to this as a pediatric provider, are our children diagnosed with autism. So this is a condition that when I started practicing 20 years ago, I might have had a handful of patients with a diagnosis of autism. And now it is like the second most common condition that I treat in terms of complexity. So that is a population that is costly. I recently was at a webinar where it was mentioned that the cost of taking care of our children with autism as they become adults is actually going to be higher than the cost of adults with cardiovascular disease in this country. To me, that was mind-blowing. And why? Because children with autism need work with education, with mental health services, with job training, with home care, right? Much more than what an adult might need who has a heart attack, right? Or needs a cabbage, right? So when you think about that, that's, again, hearings from Stephanie and Dan, that concerns me, because where will the money come from to care for these children and to help families and support them to ensure that their children are thriving? So very unsettling.
Yeah, no, absolutely. And, again, for those of us who are hoping to be advocates for children, bookmarking this webinar with those very concrete examples that you just gave us, Adriana, helpful in the months and perhaps years to come. So to take a step back for a second, I think so far we're talking about the system as it is and potential changes that are coming. And we are, of course, monitoring all of this and preparing, and we'll talk a little bit about preparation as well. But these things haven't really happened yet, right? Like we're talking about them, but they haven't really happened. So it's sort of hard to predict what's coming, as you all have mentioned. We do, though, have the benefit of recent history, and specifically what happened to the Children's Health Insurance Program, or CHIP, back in 2017. So I wonder, different situation, of course, but but about what happened and what we learned.
Yeah. We've talked a bunch about Medicaid and CHIP, and I guess I want to just call out Medicaid is this really foundational program, and CHIP is an amazing program. Stands for the Children's Health Insurance Program, if you're familiar with it. And it really just sits as a piggyback on top of Medicaid. There are so many things about CHIP that are excellent, that give states the opportunity to like design a package that's going to work best for the kids in their state. Unfortunately, CHIP is bizarrely not permanently funded. It was created by Congress. It was authorized for a series of years and funded for those series of years, but then it has an expiration date. Originally, when it was enacted in 1997, I think Congress thought like, we'll see how it goes. It's like a new pilot. We'll see if it works out. But then rather than making it permanent, they just kept sort of doing these short-term funding plans. In 2017, there was a big debate going on in Congress about repeal and replace of the ACA. And unfortunately, the CHIP program's expiration date happened to line up with that same debate. And Congress decided to use CHIP as a bargaining chip. And rather than just funding the program because they knew it was a great program with tons of bipartisan support, it was used as the sort of like political pawn in the whole debate. And to everyone's dismay and shocking almost all of us, CHIP expired in October 2017. Congress kept saying, we're going to take care of it. We're going to take care of it. We're going to reauthorize it. We're going to retroactively pay all the states the money that they should have gotten during whatever time it has expired. But the states can't bank on that. They can't take an IOU from Congress to actually pay for the services that they're providing for folks. And so what happened was that even though CHIP lapsed for about 4 months before Congress finally figured out how to renew the program and get it reauthorized. Unfortunately, during the time that the program expired, states were forced to send out notices to families saying, your child's coverage is going away. This program is not going to exist anymore. You're not going to be covered. And while the coverage never actually went away, a lot of families either fell off the program or no longer trusted that it was going to be there for them. And we lost a lot of kids. So what happened, looking back, we know that one of the big problems with Medicaid and CHIP over the course of both of the programs' histories is that there are kids who are eligible but not enrolled in the program because we haven't figured out how to reach them, because their parents don't understand the messaging, because the paperwork is too hard to get through. And this is another one of those places where we had people in the program, and when they dropped off, their families decided it wasn't worth the hassle and that they didn't trust that it was going to still be there for them. So we've done a lot of work to try to make the messaging clearer and to make it easier for families to get into the program when those programs are available. But we did see there are real consequences when Congress botches a program like this that is designed to meet kids' needs. There are long-term consequences.
And we so appreciate you walking us through what those were. Dan, is there anything else that happened in New York and the tri-state region that we may be able to learn from now?
That's a great question. I mean, I think New York has done some great things in terms of, we already talked about 0 to 6 coverage. It's expanded postpartum coverage to 12 months. It's doing some innovative things around health-related social needs, the waiver that was just approved. So in many respects, you're sort of in the vanguard of Medicaid policy and pushing the limits of what Medicaid can do. I think we just want to be careful. New York was one of the states that would have run out of CHIP funding. I don't think you got to the point of notifying families just yet, but you were on the precipice of it. And I think that experience is instructive in letting lawmakers know how real the policy consequences of these actions are. So while there probably isn't anything specific that New York, can take away from the CHIP 2017 experience, I think the subsequent experience of the ACA fight, which really elevated the Medicaid program to the national conversation in a way I think we haven't seen before, it will be instructive in terms of doing that again and making sure folks know that this has a real effect on New York. This has a real effect on New York families. This has a real effect on New York kids, including kids with complex needs, including kids with significant healthcare needs, who rely on Medicaid because they can't get that care anywhere else.
Absolutely. Adriana, I wonder, as we're talking about potential changes and things that have happened before and letting lawmakers know the real consequences that these things have for families and children that we're trying to take care of. I wonder if you can talk to us a little bit about the effects that even having this conversation, this back and forth, these discussions of things that may get cut, things that may not be anymore for families. What does that do to a family seeking to access care, if anything, and to their health?
Yeah, so I think it does a lot, Edith. And I think I've learned so much through our community health worker program in particular. These are community members, who look like our patients and who help navigate them to resources. And in that they build trust, right? So they hear a lot of things that maybe a patient may not tell me despite cultural congruence and speaking the same language, et cetera. And I think where we have such a lesson is the whole concept of that public charge that we had a couple of years ago, where families were told, and they heard it on the news, they heard it from other community members, that if they took benefits, that it might affect, for example, their immigration proceedings that were already ongoing, right? That somehow having their child in a program like a Medicaid program or the WIC program or receiving food stamps would catch up with them in a way that would be a denial on potentially their green card, right? That would be an example of that impact. And those kinds of stories really spread like wildfire in our community, instilling fear. And what that looks like on the front line for us is really that we're trying to engage patients in care and trying to maximize resources, and families are saying, no, it's okay. No, I don't need that, when we know the needs are there based on everything else we've known about the family and they're telling us, but the trust is no longer there in that government institution or organization that is an entitlement, that is a benefit that the family should have. So the impact, it is tremendous, and it requires so many different sort of tools in our toolbox to get that trust back. So it's not just a physician who takes the time to explain and sort of assess this and explore it, but other team members, a nurse who may bring it up and, in their conversation, a community health worker, a teacher, right? Other members of our community, a clerical member, right? A clergy member, excuse me, who might, again, say, it's okay, get the WIC program. So it really takes kind of the entire village to recover from something like that. And I would say we're still in some effects recovering from the public charge, right? Which was now, maybe 4 years ago? I can't keep up anymore. Maybe 6 years ago. But the impact is there.
Yeah, and it's I couldn't agree more. We're still recovering. I still have many families who unfortunately decline services that they are entitled to and very much need because of this lingering fear and lack of trust. Stephanie, we've talked about this and touched it in different ways at different points in our conversation, but for the pediatricians and the parents who are listening this evening, what are concrete things that we can do to advocate for children in this moment?
Yeah. While we are waiting to know exactly what we're talking about with Congress, we need stories. The AAP will be asking pediatricians to share your stories with us in the coming weeks. So if you are an AAP member, look out for an email. We'll be formally asking in a variety of ways. But for anybody who's in practice, anybody who's working with families, if there are families who are on today who have stories about why Medicaid matters to you, it's really important to share those with your member of Congress. Those policymakers need to understand how impactful this program is in supporting the health and well-being of people, especially kids. We know that even though Congress may try to isolate the impact of any cuts so that kids are not affected, that when you start cutting the program overall, when you ask a state to take on the financial burden of what was previously federal spending, states have to get really creative with the ways that they respond to that. And the only levers that states have available to them, right? They can cut down on the number of people in the program, which means that you have more people who are uninsured. They can cut down on the benefits that they cover, so cutting down on the services that are available. So if you're enrolled, the coverage just might not actually get you the care you need. And they can cut down on how much they're paying for what they cover. So they can cut down on provider payment rates, on hospital payment rates, on what they're willing to pay for other services. And that means that it can be a lot harder to find a doctor when you need a doctor. That means it can be a lot harder to get an appointment when you need an appointment, that you might have to wait months for your kid to be able to see somebody that they need to be able to see just to be able to get routine care. And we know that that's unacceptable, that it's not okay for kids to be missing care. And those are really the only levers that a state has to be able to address when they don't have enough money to pay for the program as it is. So that's a real impact, especially for kids. As I said, almost half of all kids in the country are covered by Medicaid. And that means for pediatricians, for children's hospitals, that Medicaid is a huge part of keeping the lights on, keeping the doors open, being able to hire enough pediatricians, being able to hire enough nurses, being able to hire enough front of office staff. And so if Medicaid gets cut, if payment rates go down, if a whole bunch of kids lose insurance, that the business case there means that they're going to have to make cuts as well. So they're going to have to offer fewer hours or not hire as many people, which means there are not as many appointments. And all of those things mean that kids' access to care gets hurt.
Yeah. Dan, anything to add? And just for everyone, we will have a few minutes for questions if you want to submit them now through the Q&A. But Dan, I wonder if there's anything that you want to add there.
Well, I'd echo everything that Stephanie just said. I think we're trying to be strategic as to timing. We'll be reaching out to chapters and members as things crystallize in Washington and as we have a better sense of how to fight exactly what we will be fighting. So more to come, and as Stephanie mentioned there, I think the other thing you can be doing is just talking to your coalition partners now. It's really a matter of being ready. And I think the stories, data is important, but stories really happen to win the day. And the more, when we ask for stories, the more you can send them in, the better. And the more you can share those also, again, with your state level folks, your state lawmakers, your state agencies, your governors' offices, because they have a vested interest too in what happens in Congress, and they're going to be the ones who have to address it. So just to add that piece of it, but a lot more to come from the Academy, and I think if 2017, I was at the Academy in 2017, and I think it was a tremendous galvanizing moment for everyone to fight the ACA fight, and I think we will face something similar again, and it will need everyone to share their stories and to be successful. So a lot more to come, and thank you in advance for sharing when you do.
So Dan, you mentioned preparing. So this is and I'm just going to acknowledge that it's a loaded question, but Stephanie, how can systems prepare? There's so much uncertainty. There's so much that could happen, but we don't know exactly what it's going to happen yet. So how can systems prepare at this time if there's anything at all that we can be doing?
Yeah. So as Dan mentioned, there's a lot of places right now where we're trying to walk and chew gum at the same time, right? We're trying to prepare for this big national level debate and fight. And we also have to keep operating on the program that we have today. We lost, as Dan said, about 5.5 million kids were dropped during this process called the Medicaid unwinding, where at the end of the COVID public health emergency, state Medicaid programs had to go through this enrollment renewal process, and a bunch of kids fell out of the system, and we don't know what happened to them. We think most of them became uninsured. So there's a lot of kids. So there are a lot of things, their family support, their outreach efforts to try to help families get into coverage. If you come across a kid who doesn't have insurance, Medicaid and CHIP do not have open enrollment periods. They are open all the time. You can enroll any day of the year. And that's a really important part of this, is to make sure that the kids who are eligible for the program are getting into the program. That also makes sure that we have the best knowledge about who is likely to get impacted if these program changes actually do take effect, so that we're not making assumptions based on who we think might be eligible, but actually we have all the people who really should benefit from the program already in the system. It's not a great answer.
No, We appreciate it. I mean, it's really let's try to get families signed up for what they're eligible for right now, right? And that will sort of set us up to be able to react or respond to changes that are coming, right? Adriana, I wonder what you as an individual pediatrician or within the larger community here at Columbia are doing to prepare.
Yeah. So right now we're in the process of organizing with our community agency partners, who are, again, it's the boots on the ground, right? It's not the doctor sees the patient maybe a couple of times a year, right? But it's creating these partnerships with the community agencies that really are in touch with our families as a population, right? So right now we are working actively with them to engage in messaging, to understand what messaging is reasonable, feasible within our practice settings, because it is a point where we connect with families, whether that's educational materials, bullet points that pediatricians can potentially utilize during the visit to, create that safety net environment. And then logistics, as soon as the information comes, right? So it's about a good system of disseminating that information as it comes with new rules or new regulations, so that we're not basing our reaction on rumors, but rather like the facts of what the next steps are. So right now it's really creating that partnership, Edith. But there's a lot of sort of, on the ground concern about accessing care even now that I'm already getting feedback from our community health workers that people are just a little bit concerned. They're just not so sure whether it's safe to already seek care, and we're not even at the administration being in place.
And it's I mean, that's really what's going to make a difference in the long run. Those boots on the ground and those trusted relationships and partnerships. Let's tackle a couple of the questions. I think we've answered a few. I think there may be a couple more that we didn't get to yet. There's a question about how do differences in eligibility and coverage between Medicaid and CHIP impact access to healthcare for migrant families, particularly those with undocumented children or mixed status households. Adriana, do you want to tackle that one?
Yeah, so the children who are asylum seekers or in that process already with their immigration proceedings, they are on Medicaid. So they have the best benefit package that we have currently. So in New York State, they're on Medicaid. Again, this is state by state, but in New York State, they are on Medicaid and they are getting all their services covered. So that's different from an undocumented child who may not be with asylum seeking procedures. That child would be on Child Health Plus. That's their best alternative. And that, we get into what we discussed before. So they may have more copays and the benefit package is different. But for hospitalizations, for acute emergency care, all of that is essentially the same, as I understand it to be. But we'll see that actually can also change, right, moving forward with a new administration. But that's how it's been. And I'm optimistic that in New York State, a lot of those protections will hopefully hold. But again, TBD in terms of what New York State and New York City has been able to do historically, whether or not they will continue to be allowed to be, as flexible and open in those supports for undocumented children.
Yeah. So helpful to understand those differences, really. There's a question that came in, and Stephanie, I'll pose it to you, but it may be a bit beyond what you may be able to tackle at this time, but maybe you can comment. Feel free to tell us if it's a bit beyond what you're able to tackle at this time. But the question says, how is the AAP position in itself for new leadership at CMS?
Very good question. For those who are not speaking Medicaid acronym wonkdom, CMS is the Center for Medicare and Medicaid Services. It's the agency within the federal government that oversees the federal branch of Medicaid and Medicare. It's right there in the name. So there are some new political leaders coming in right now. The person who has been the intended nominee to run the center to run CMS is Dr. Oz. You may have seen him on daytime TV. And he doesn't have a lot of policy background. He really, he was a practicing surgeon and then he became a TV host. And so knows a lot about a lot of things, but does not have a lot of experience in policy spaces. So as this question has accurately pointed out, there is a lot of unknown there, which we know means that they're assuming that he is confirmed. so far, I don't have a lot of intel to suggest that he wouldn't be confirmed. If he does take that job, then there will be a lot of opportunity to educate him about how important Medicaid is for kids. I would bet that he doesn't know a lot about the program yet. So there is a really good opportunity there. We also, the AAP is always working. I mean, if you haven't heard of it yet, I will tell you we are a nonpartisan organization, but we are unabashedly pro-child. We work with every administration, we work with every party, and we will always find opportunities to make sure that people understand what the evidence shows us about what works best for kids, and that we work to find ways to promote those policies that are going to do the best to promote child health. There are also inside the Beltway speak, we have there's the political folks, but there's also a lot of career staff, career federal employees who have been at the agency for years, in many cases decades, and they have been through many different political administrations, many different eras of the programs, and they are great partners. They really do understand how the programs work, and we have good relationships with a lot of them to make sure that the program is working as it is intended to.
Great. I think that was our last question. We have a moment for parting thoughts from all of you. Maybe I can go to Adriana first.
Yeah, I think takeaways for me is really advocacy, right? I mean, that's what I'm hearing. So as physicians, we've taken on a role to take care of children and to provide healthcare and to support families. But we have a voice, and we have a voice that's quite respected with our legislators. And so to not shy away from that, the time is to step up now. So not only can we make a difference one-on-one in our patient rooms at our practices, but we can go beyond that. And that's really super, it's very powerful. So I think we need to embody that. I feel emboldened tonight. I do feel that the sharing of stories is a critical piece to that. In my experience, sharing those stories has helped me get grants, philanthropic grants, because people want to hear that to move them to then help them make the decision. So I feel emboldened tonight.
We appreciate those thoughts, Adriana. Dan, let's go to you next.
I would echo that, Adriana. I'd say just first of all, thank you for having us. I think this is an important discussion and great that we could talk this through for an hour. Much more to come from the Academy. And I think we're thinking about you, knowing that you all are really busy. And we're thinking about advocacy in different bite sizes, so if there are things you can do in 2 minutes or 5 minutes, or if you have time to write letters or record stories. So we're kind of thinking about all of that. So a lot more to come from us. And again, thank you. I'll just say thank you in advance, because we know how much of an advocacy effort this is going to take, but we're ready for it. And we're going to rely on all of you on the ground to really make it happen. So much more to come. Thanks.
Love it. Stephanie.
Plus one to what Dan and Adriana both said. I think one thing I guess I can share, we, again, as Adriana said, the coalition work here is really important. And the AAP is part of a lot of coalitions that are active supporters of Medicaid. We have a lot of really good partnerships, including particularly with organizations like Family Voices, which represents families who of children with medical complexity. And we know that those stories together are really powerful, right? The experience of a family with a kid who relies on Medicaid for their daily care, and the experience of pediatricians who can speak to the whole impact of Medicaid on their patient population are really impactful. I will share, Dan and I are here. Our job is to sort of pull together all of the evidence so that we can have the data. It is really clear Medicaid is a really important program. It works very well to support children in the short term and in the long term. And there's really no debate about that. What we are going to rely on the rest of the community for is to pull together those stories that really change the hearts of the policymakers who are going to be considering this, right? The numbers, the data, the cost estimates, all of that will change the sort of political negotiating that happens. But when it comes down to a vote, what's really going to matter is the stories about the people who rely on the program.
And we so appreciate that reminder. And we just had a really nice note come in from an elementary school nurse in a district that will be impacted by these potential changes, who found our dialogue really impactful. So what a better way to end. And I think last minute question came in about when would you need these stories by? And I think TBD, right? More information to come from the AAP on those timelines and what's needed. I'm really just so grateful I learned from all three of you tonight. I hope that everyone at home did as well. Thank you so much, truly, for joining us. We will be sending out this webinar to everyone who registered. If you found it helpful, send it to a friend. It will be on YouTube. I will bookmark it because I do also hope to be advocating for children in the months and years to come. And I think there's so much information that we discussed tonight that can definitely be used in advocacy efforts and again, the creation of meaningful partnerships. So thank you all so much. I'll see everyone in February. Thank you for joining us tonight.